Hello.
Yeah, hi Dr. Tho.
Hi,
Good evening,
guys.
Dr. Tho.
Hi.
Okay. Yeah. Welcome to the series today. Yeah.
Okay.
Yeah. Dr. Tho will just give like just a few minutes to admit some of the participants, if that's okay.
Sure, that's fine.
Alright.
It's this group would be a combination of third year and final year, is it?
Yeah. I think that there will be some second year who tune in, but yeah, I think mostly it will be clinical year students.
Okay.
Yeah.
Sure. Let me know when you guys want to start then.
Alright. Yeah, sure. Hi, Doctor. My name is Kenneth, and I'm a third year medical student. And
Okay.
with me today is another second year medical student called Amanda. So she'll be co-moderating with me
Sure.
throughout the session. Yeah.
Sure. Okay.
So now we'll just wait like a few more minutes, then we'll start.
Yeah, sure. Let me know.
Okay. Thank you, Doctor. All right. Hi, doctor. Yeah. So I think we'll start. Make a start now, lah.
Okay, sure.
All right. So hi everyone. Welcome to the case by case basics. So my name is Kenneth. I'm a third year medical student from the University of Malaya, and the co-moderator for me with me today is Amanda, who is a second year medical student also from University of Malaya. So today we have with us Dr. Tsun from the Division of Neurology, Department of Medicine, University of Malaya, to discuss with us two cases about epilepsy and seizure. And so we'll go through an approach to epilepsy. All right. So yep. We'll move to the first case. Yeah. Okay, so this is some of the learning points that we have today. So basically like definition of seizure and epilepsy and some approach to epilepsy as well as classification, etiology, investigations, and also the principle of management. Yeah. So this is the first case we have. All right, so I'll just read out the prompt to you, doctor. Yeah. And then we'll just discuss the case as we go along.
Sure.
Yeah, so the first case is Mrs. X, a 26-year-old Malay girl, presented to emergency department with a seizure episode. So a seizure episode occurred in a Grab car when she was on her way to return home after feeling unwell. So she felt nausea and drowsy, and she saw some flashing light before the episode. So she told the driver to send her to the hospital if she became unconscious. So she regained her consciousness in the hospital, and she felt drowsy and could not recall anything after she woke up. So yeah, so this is the presentation of the patient. So we know, she had a seizure episode. It was mentioned there. Yeah, but the first thing, that we would like to ask our participants is, according to the prompt just now. So what are some of the differential diagnoses that we can think of? Aside from being seizure alone. So you all can join the Mentimeter using the code 1277313 in the chat. So you all can just go to Mentimeter and I'll sure. Yeah, so if I get a response, okay, so.
Sorry, the Mentimeter is for them to answer the questions, is it?
Yeah, for them to answer the question.
Okay.
Then I'll just let you know, doctor, some of the diagnoses.
Sure.
Yeah. So I think we have a few here. We have migraine. We have hypoglycemia. We have syncope. Hypoglycemia. Migraine with aura.
Sorry, I didn't get the because the line was a bit laggy.
Okay, I'll repeat for you, doctor. Yeah, we'll just give like a minute or so for the participants to just put in some answer.
Sure.
Yeah. Okay. Yeah, so doctor, we have a few answers. Basically, we have migraine with aura, we have hypoglycemia, we have syncope, we have multiple sclerosis, we have thoughts paralysis, migraine, we have electrolytes imbalance, raised intracranial pressure, syncope and hypoglycemia, TIA or stroke, febrile seizure.
Okay, that's a very, very wide range of answer.
Yeah, actually, just to prompt the participants to give a few Yeah, but then we can proceed. I think. Yeah, doctor. So in terms of this case, after you look at the prompt, is there any differential diagnosis, a particular differential diagnosis that you could sort of give us?
So I mean, the list there was quite extensive. Some are very relevant to the case, while some others are not impossible, but probably less likely or down the list. So someone mentioned migraine just now, right?
Yeah.
Which is fair considering. Do you mind if we go back to the prompt just now?
Oh, yeah, sure.
Yeah, which is fair in. I assume the trigger for migraine was because of these symptoms of nausea, drowsy, and some flashing lights before the episode. But what or what do you guys think makes would migraine be likely here? And if it's not likely, why? Or if it's likely, why? Do you guys want to try that question?
Maybe that will put it in the chat box if there's any answer for that.
Yeah, so because for migraine with aura, yes, you can consider that. That's not wrong, but usually there are some clues that will tell you, oh, this is very likely to be a migraine attack. Well, there are some negative or there are some other information that tells you this is likely not a migraine attack.
Yeah. See if there's any. Yeah. So you all can put in like the answers inside the chat box.
Yeah, someone said unlikely as usually won't have altered consciousness.
So in terms of migraine, is it that it won't be the patient might not have like altered consciousness? Is it correct like that?
Most of the time, yes, but sometimes for a certain type of migraine with aura, yes, you can have altered consciousness. So can anyone tell me what's the type of migraine that might give you altered consciousness? Someone said unlikely because of no headache. Yes, that is somewhat correct, but migraine sometimes can come with just aura without the headache. So it depends on the past history of the patient. If the past history of the patient shows a lot of migraine with headache, this time the aura did not come with a headache doesn't mean that it's not a migraine. Sometimes the aura happens without the headache. But of course, in a setting of a patient having aura headache in the past, then only you can diagnose this is migraine with aura.
So would it be like if it's migraine, then most likely the patient would have episodes of migraine that before this, and then they would tell us that they usually have headache.
Most likely, unless you are unlucky enough to have a first onset of migraine headache. Yeah, but I mean at this age, usually migraine does happen. Someone says likely due to presence of nausea and positive visual symptoms. Likely migraine, I assume you're saying. Well, the nausea usually happens during the headache rather than before. They can have nausea before, I guess, but more commonly or more prominently, it happens during the headache. The positive visual symptoms, yes, can happen before the headache as an aura. So back to my first question just now. If let's say it's a migraine and there's altered consciousness, what type of migraine do you think it is? Anyone has any idea? Bacillata, yep, correct. So there's a migraine called bacilla migraine or bacilla aura. So for this type of migraine, you can have altered consciousness.
All right.
Okay. So, but usually the attack would be aura, as in migraine in general, migraine aura, followed by a headache. That's the most common one. So if you have a first onset without headache, it's very hard for you to say migraine unless there are previous episodes like I mentioned. So the other differentials that were given were what again? Hypoglycemia, is it?
Yeah, I think we have hypoglycemia, electrolyte imbalance.
Yep.
That's the metabolic causes.
Yeah, the metabolic causes are fair, especially things like hypoglycemia with drowsy, nausea. The flashing light is a bit unusual though. Usually they'll have more hypoglycemic symptoms like sweating, cold hands, hunger, and they usually would have a cause to the hypoglycemia, diabetic with medications or Munchausen or something. Electrolyte imbalances, maybe lower because sounds very much like a fairly subacute onset rather than a long-standing kind of thing. What are the other differentials again?
I think we have TIA and stroke.
TIA and stroke. Usually, for your level, stroke TIA will present with negative symptoms. So this one has a positive symptom. Flashing lights. Flashing light is a positive. So positive symptoms is when you feel more things or you see more things. Negative is when you have numbness, you have loss of vision. That's negative. If you have flashing light, you have paresthesia, you have weakness. All those are negative. So stroke TIA more likely negative. Not impossible, but down the list as well. Plus, she's so young, and stroke wouldn't be a very high differential.
All right. Yeah.
What else was the differentials again?
We have also let me see again. I think we have syncope. Yeah.
Yep. I guess syncope can still fit in well because we don't really have enough information here to tell us syncope or not.
Yeah.
If it's syncope, what do you expect to find in the history, or what are you looking for in the history that tells you this is likely a syncope?
Like it's more transient, is it?
Yeah, more
like
transient.
The patient actually
yes.
recover faster.
Yeah, will recover much faster than a
seizure. Yeah, and there wouldn't be like a post ictal drowsiness and things like that.
Yep, correct.
Although we haven't gone through that. Yeah.
Yep.
Okay. All right. I think that's almost about the differential diagnosis that you have. I think we also prepared a bit on the differential diagnosis. Also like syncope. How about like non-epileptic seizure, doctor?
Yeah. I mean, for us, when we see seizure patients, pseudo seizure or non-epileptic seizure is always in the back of our mind. As a diagnosis that it's a very difficult diagnosis. You need to exclude out the other causes first before you can say this is a functional or non-epileptic seizure. There are certain clues to tell you this could be like a possible pseudo seizure. Do you guys want to try to see what are you looking for if you think, or what will you find in the history if you think this might be a pseudo seizure?
Yeah. I think it would be something like a trauma history, like a physical trauma, abuse.
You mean
like mental illness.
Emotional kind of
like a physical stress. I mean like emotional stress.
Yep. So number one, if you have a baseline psychiatric disease like depression or some form of anxiety or something, or you are a bit more likely to have non-epileptic seizure. Or if you have a psychological issue or stressor that's very prominent, you think the patient is in very high stress recently, yes, correct. That's one sort of risk factor you would look for if you're considering a pseudo seizure. Anything else?
Yeah, I think that's about it for the differential diagnosis.
Mm-hmm.
Yeah, so in terms of like which is most likely, I think can we say like which is most likely, and I mean like the least common ones, which one?
Yeah, at the moment, I guess seizure is top of your list. You can say syncope because, like I said, we don't really have enough information to say yes or no. Hypoglycemia is still in the list. Interruption of blood circulation, I assume, is something like TIA or stroke. Not impossible, but less down the list. Similarly, migraine is also down the list. Sleep disorder, probably not because she's not sleeping, right, technically.
Yeah.
Movement disorder also is unusual to cause any altered consciousness.
All right. Okay. So I think we can move on to the history of presenting illness. Yeah. So all right. So this is the history. So the Grab driver actually told her that she started having fits when she had bilateral uprolling eyeballs, stiffening and jerking movements of her hands and leg bilaterally. So she also had drooling of saliva, and the episode lasted about 5 minutes, and she lost consciousness. So this is not associated with urinary or fecal incontinence, no other injuries, no paralysis after the seizure. So she denied any profuse sweating or feeling of hunger, shivering, or chest pain, or any prolonged standing before the fit started. So I think before that, 5 days before this, she was feeling unwell. She had some intermittent fever, non-productive cough, and headache. And then she also had some vomiting, I think. Yeah, runny nose, sore throat, and also some shortness of breath. Yeah. So, all right. So looking at this history of presenting illness, I think we can sort of say which is like the semiology of the seizure itself. So I think pre-ictal she was nausea, drowsy, and some flashing light, saw some flashing light, and then ictal she had bilateral unrolling eyeballs and stiffening and jerking movements, and then she was drowsy after post-ictally, and she could not recall anything after she woke up. So I just want to ask everyone, what type of seizure is this? So I think we'll use the Mentimeter again. So I'll put up the question so we all can answer.
Maybe also try to say why you think it's what type of seizure and why you think it's that type.
I think we have the first one is generalized tonic-clonic seizure, and then we also have temporal lobe seizure. We have generalized seizure and focal and lateralizing signs present. Focal seizure because there's lateralizing signs present. Generalized tonic-clonic seizure because it involves four limbs. Generalized seizure, generalized tonic-clonic seizure. I think we have a split between. I think mostly it is generalized tonic-clonic seizure, and then I think there's a few who said focal and temporal lobe seizure. Focal temporal lobe seizure.
Okay, so for those who said focal with some lateralizing signs, what is the lateralizing sign? Which one is the lateralizing sign?
Can we see in the chat if there's any answer? I think in terms of the lateralizing sign, maybe it's more of a localizing sign to the lobe, I think. Because I think mostly it's bilateral, so it's not really lateralizing anywhere.
Yep. Yeah, so that's why I was interested for those who said lateralizing signs, which was the lateralizing sign actually?
Yeah.
Or which one is the one that make use? What clue is in that information that tells this could be focal?
I think one of them actually said uprolling of eyeballs.
Uprolling of eyeballs, no, not really. Uprolling just means it's a generalized sign. Uprolling doesn't mean focal or generalized. If you have uprolling, most likely it's a generalized. So someone said aura, so that flashing light, is it, I assume?
Yeah, I think it should be the flashing light.
So for flashing lights, which lobe is most likely the cause? The localization? Is it temporal?
I think it would be more of a occipital.
Yep, correct. So for flashing lights, the most common place or the most common location for this aura is actually occipital. So the correct answer to what type of seizure this is most likely is a focal to generalize with a secondary, or some may call it secondary generalization. Of course, you might argue that you don't have enough information to know you are really having focal to start with. So basically, we are only basing it on the flashing light as an aura. Because by the time the ictal event happened, or by the time she is jerking or stiffening, it's already a generalized tonic-clonic spread. So the only clue you have is actually flashing light.
Yeah. Okay, so in terms of like this, right? If it's a primary like generalized tonic-clonic seizure, they wouldn't have aura, is it?
Yes. Primary generalized tonic-clonic seizure should not have a very focal aura. I mean, they might get a bit of tiredness, lethargy or something, but those are all non-specific ones and might not be aura per se. Usually only focal ones get very prominent aura. And when we say aura, it's very characteristic. Most of the time when the patient has seizure, right before the seizure, the same aura happens. The same feeling, the same sensation, the same flashing light. So there's a pattern to it because the discharges in the brain would start at the same place every single time. So that's why the sensation will be the same. It's not something that evolves over time. Of course, there can be some variation over many, many years, but in general, the aura should be the same. If the sensation of numbness or tingling starts in the hand, then it will always start in the hand and spread slowly. If it's flashing of light from one side, then most of the time the aura would be the same flashing of light from the same side. So you can use aura to help you localize which lobe is likely involved. So there are many, many types of aura. Flashing light is just one of them.
Right. Okay, so I think in this case, yeah, we can all agree that this is a secondary generalized tonic-clonic seizure. Yeah. So yeah. So the next slide is just to highlight some of the classification of the seizures. So we have focal and generalized. So in terms of this, doctor, is there any can we just discuss like a bit on some of the some of the seizures like in terms of focal and generalized, like what are some of the symptoms that we normally look for in like more prominent symptoms that we can ask in our history for this for like the seizures, each type of seizure.
You mean based on this table or in general?
In general, yeah. To sort of like differentiate, like let's say focal and generalized, and also to differentiate like let's say it's a tonic-clonic or it's myoclonic. Yeah.
Okay. So pre-ictally, like I mentioned just now, if there is a presence of aura, then you should be thinking of focal rather than generalized, even if the seizure might look generalized from the history taking. For generalized seizure pre-ictally, you probably might not get much or might not get much clue. So when the ictal phase comes on, you would be looking for all this. For generalized, it will be tonic, clonic, or tonic clonic. They might come in succession, meaning they might go tonic first, then clonic, or they might go right away to clonic, might go right away to tonic, or they can alternate. For myoclonic, it's a bit different, where it happens a bit faster and usually happens in either one or a few jerks rather than a tonic that happens continuous and rhythmically. Myoclonic jerks can happen by itself, as in without a full-blown seizure. So there's a condition called juvenile myoclonic epilepsy, where usually their symptomology when they have a seizure is a GTC, but they can have myoclonic jerks during other times, especially in the morning. So the classical history for them is usually onset at a teenage age. And early in the morning or sometimes even at night, they can have these jerks that happen, like let's say they're brushing teeth, suddenly their hand jerks and the toothbrush falls, or they're eating breakfast and their spoon falls down with the myoclonic jerk. So there are other rarer types like atonic, epileptic spasm. These are usually more, the onset of this type of seizures are usually more during childhood or pediatric age. Then there are non-motor types with absence, typical absence where you get blank stare, so they are typical and atypical, but I don't think you need to know the differentiation between these two at the moment. Then for focal, the clue is usually a lateralizing sign, like you mentioned. You look for the eyes, eye version to one side, a face that's jerking or twitching by one side, a limb or a upper or lower limb that's jerking by one side, or sometimes even a body turn, as in for certain seizures, every single time the body will turn to the right side, let's say. So you know there's a focality there. There are also other things like written on the table there, like automatism. We have automatism, especially things like oral automatism or hand automatism. You know this is likely because oral itself is a focal sign already, because the automatism only happens in the oral part. Then if you have a hand automatism, usually it's one-sided. So you will know that this is likely a focal type of seizure.
Okay.
The non-motor ones are quite quite rare. I mean, sensory, yes, you can argue this sensory part might be the same as the aura that you're feeling, but the others like cognition, behavior arrest, autonomic, emotional, these are rarer types of presentation. Not impossible, but rarer type of presentation for focal seizure.
Okay. Alright. So I think yeah, thanks, doctor. So I think we'll move on for now. But if anyone has any questions regarding like the types of seizure, and also like some of the questions, any questions you want to ask for the previous slides, you also can just put in the chat box. Yeah. So I just have to ask doctor. Yeah. So meanwhile, we just move on to the next one. So actually, I would just like to ask, because she was also feeling unwell for 5 days prior to this admission, having like intermittent fever and also like cough, which is sort of like suggestive of like a infection or sort of like a respiratory infection, because she also has shortness of breath. Yeah. So doctor, in terms of this, we would discuss some of the precipitating factors. So in terms of like infection, could it be one of the precipitating factor?
You mean as a trigger for a seizure?
Yeah, as a trigger for the seizure.
Yeah, definitely. This is one of the more common triggers. An infection, a URTI, AG, unwell. So all these can trigger a seizure episode for patients who have a predisposition to get seizure.
All right. Okay. Doctor, so about other like triggers? Is there any more common triggers that we can talk about?
Yeah, so the common ones, I think you've written down there. The usual common ones are number 1, infection, number 2, stress, tension or stress at work or whatever, or sleep deprivation is also a very important trigger. Lack of sleep, not enough sleep. Then alcohol withdrawal is it's a cause of the seizure rather than a trigger.
Okay.
Yeah, flickering lights or music, these are quite specific for only certain types of seizure. The main for flickering lights is for seizures which are photosensitive. There are certain types of seizure we have. Not all seizures will be triggered by flickering lights.
Yeah.
Menstruation, yes, there are some patients who have tendency to get more seizures peri-menses, as in before, during, or after. Usually this is related to the hormonal balance, where estrogen and progesterone. If I'm not mistaken, a high estrogen exacerbates seizure, while high progesterone actually reduces seizure occurrence.
All right. Okay. Yeah. So yep, I think all right, we can move on. So next is actually I think we have gone through some of these questions in terms of we just like to ask like what other than those that we asked in terms of the medical history, is there anything that we should ask other than what we have gone through? Like what else could we ask? Or what are the common things that like medical students actually miss when they take a medical history for seizure and epilepsy?
In terms of history of presenting illness, I think most of the things we have covered just now. Probably you can go a bit more in detail about the post-ictal episode, where if there is a witness, if let's say you can grab hold of the taxi driver or something, ask in more detail, how is she? Is she like just drowsy, not answering questions? Is she awake? Is she confused? Because those are the different clues that will tell you this is likely a seizure rather than the differential diagnosis. Then you probably need to get a bit more history on the event preceding the episode. I mean, I think this patient just got on the cab from somewhere and wanted to go home because she felt unwell, but we weren't sure where she came from, what was she doing. Was there, let's say you switch up the scenario, this could very well be, I mean, if you don't have, this could very well be something like a vasovagal syncope kind of history. She might be exposed to something before she got the cab, like let's say hot weather or prolonged standing, or maybe even seeing some, excessive pain or seeing some blood or something. But of course, knowing all the details that we saw during the history taking, or I mean the details that support seizure makes a vasovagal syncope unlikely lah. Plus, she was already sitting in the car before the event happened. But you should always consider that lah when you take the history.
All right. Okay, doctor, there's a question from Grace. Hi, doctor. Seizure triggered by infection is common in all adults, or only adults who have more predisposition to seizure. More predisposition to seizure means that the patient has underlying epilepsy.
Yes, infection that are not intracranial, as in non-meningitis, non-encephalitis, should not be a cause to the seizure. Meaning, a UTI shouldn't cause the seizure, a pneumonia shouldn't cause the seizure unless there are some intracranial involvement. So if a seizure is triggered by an infection, then most likely, or put it another way, yeah, you're right lah. A patient who has a tendency to have seizure or is epileptic would be more likely to have this trigger by infection history. So you have to understand the cause of the seizure or the etiology of the seizure and the trigger of the seizure are two different things.
Okay. Yeah, I think in terms of etiology, like something like central nervous system infection would be the cause etiology of the seizure, but like infection in other systems would be the trigger.
Yes, but if let's say I change it up, you have a TBI, a traumatic brain injury, you have an encephalomyelitis in the brain, so you have a tendency to get seizure, right? Because you have a scarring in the brain. So even for these patients, you can have a infection triggered episode of seizure.
Okay. Yeah. All right. So yep. I think we can move on to the past medical history. Yeah, so actually the patient was diagnosed with epilepsy 3 years ago. So she had done a CT, MRI, and also PET, and also EEG. So the EEG showed that she had occipital malformations. Since then, she had a total of 10 hospital admissions due to seizure, and current one is the 5th one in this year. So she had a 3-monthly follow-up in the UMC Neuro Clinic. She's compliant and tolerates her medication. She's well, except some drowsiness after taking the medication. And sometimes she claims to have right-sided limb stiffening and jerking associated with mouth deviating to one side, drooling of saliva, and tongue biting. So most of the times it would abort. It will abort spontaneously, while sometimes it aborts after giving anti-epileptic medication. So she would need to rest for 1 to 2 hours before she could fully recover. Yeah. So 9 months ago, she was also diagnosed with vasovagal syncope by a tube table test. Yeah. So doctor, in terms of like she claims to have a right-sided limb stiffening and jerking. The part, is there any significance to that in terms of the seizure?
Yes, of course. That tells you that adds a lot more weightage to focal epilepsy rather than a generalized epilepsy. And the right-sided symptoms would likely point that her occipital malformation will be more on the left. You can also when the patient said, I forgot to mention this, when the patient said flashing light, you can probably also ask where is the flashing light? Is it coming from the right, coming from the left, starting in the middle? So that might give you a clue to which visual field the discharges are coming from.
So in terms of like the patient has the occipital malformation, so like wouldn't be some of the focal, like the lateral, the localizing sign to be more in the occipital region, the occipital, instead of like having like limb stiffening and jerking, which is not.
Okay, why do you think an occipital malformation can cause stiffening, jerking, or GTC even? Is it because the occipital control the motor?
Not really.
So why would they get a full-blown seizure? What happens in the brain?
When it spreads to the.
Yeah, correct. So the stiffening, the jerking is the spread, either spreading to the basal ganglia, causing some dystonia, or spreading to the motor cortex, causing these jerky movements. Okay. So the aura tells you that it probably starts somewhere near there or starts there lah. you can say aura is usually the first presentation or the first sensation of the patient when the seizure starts. So you assume that that's where the seizure is starting from. But of course, there can be we have seen cases where the seizure focus is actually a bit further or a bit deeper in from the aura part. How do I say this? Sometimes the first presentation might be a dystonia or a tonic kind of movement, but your seizure might be in the your epileptic focus might be in the temporal lobe, that the patient might not have a sensation or might not have aura too. So yes, you assume the aura localizes the malformation or the epileptic location in most cases. So like her case, the visual hallucination does localize very well to the occipital malformation in MRI.
Okay, yeah. So I think we have a question. So hi doctor, just to clarify, if a patient has a history of seizure secondary to meningitis but has recovered, will they be diagnosed as epilepsy as they have predisposition for future seizure?
Depends. If you have acute seizure secondary to acute meningitis, your risk of developing epilepsy is lower compared to if you have a remote seizure or remote symptomatic seizure. Meaning, let's say you have meningitis now and you have seizure now, compared to a patient where you have meningitis 2 years ago and you have seizure now. So the recurrence rate for these two conditions are different, where the one who had seizure 2 years after the meningitis has a much higher rate of seizure recurrence. But the former group where you have meningitis and seizure at the same setting or within that 2 weeks, you still have a higher tendency to get epilepsy or to get recurrent seizures compared to someone who is normal or someone with a very reversible cause like hypoglycemia and all that. I don't know whether that clarifies the question or make it a bit more confusing.
Okay, so in terms of remote symptomatic, how long would it consider a remote if it's?
Anywhere below 2 weeks is acute symptomatic. Anywhere more than, if I'm not mistaken, more than 2 months is remote. But the in between is a gray area. You can say more than 2 weeks is remote.
All right. Okay. Yeah. So all right, we'll just come back to the case first. Also 9 months ago, she was diagnosed with vasovagal syncope via tilt table test. So I think in terms of vasovagal syncope, just now you mentioned, it will also play a big part in terms of like our differential diagnosis if we see that the patient actually has vasovagal syncope.
Yeah, though I'm not sure why she was sent to a tilt table test to begin with.
Yeah. Okay. All right. So we move on first. Okay. So on further history, she's currently taking sodium valproate, levetiracetam, and fludrocortisone. So she has no known drug allergy. She has no family history of seizure, and also other malignancies. So she works as a medical clinic assistant, and she's paying her bill herself. So she does not smoke or drink alcohol, no food allergy, no specific diet restriction, and she only exercises once in a month. All right. Yeah, doctor. So we come to the drug history. So in terms of drug history, I think most patients they take sodium valproate and levetiracetam.
Okay.
So most patients, I think they only go for like monotherapy in terms of like two types of drugs. When is it indicated?
So actually, for this patient in particular, there are a few issues, I would say. Number one, the seizure is obviously not controlled. So you have to determine whether the poorly controlled seizure, is it due to patient factor or is it due to the disease factor? As in, is the problem a resistant epilepsy that no matter what you give or how much you give, the seizure will always come because the recurrence rate is too high? Or is it because the patient is either not or maybe it's the drug problem? The patient is not taking enough doses or high enough doses. The patient is taking the wrong anti-epileptic for the type of seizure, or the patient is not compliant. Or another thing you can consider would be whether the patient keep getting a trigger, as in the epilepsy might be stable, but the trigger keep happening. She keep getting lack of sleep every single night. She works night shift every 3-4 days a week, or work or family stress is consistently there. No matter what you do, she still feel very stressed out. So you probably need to ask more about this part, because in terms of the management of the patient is probably important. Why would the patient be on 2 anti-epileptic? Goes back to whatever I mentioned just now. If your seizure is poorly controlled with 1 anti-epileptic, what we usually do is add on. But you also have to keep in the back of your mind is whether the patient is taking the medication, whether the drug is correct, whether your dose is correct. So my question would be, is the medication correct?
I think yeah, can get some answer, but I think for me, I think the drug should be correct for sodium valproate and levetiracetam. I think
Okay.
sodium valproate would be the first few. I'm not too sure if levetiracetam is actually the first line for generalized tonic.
So in terms of the correct choice of drug, there are also a few considerations. The most important consideration is usually whether this is focal or generalized. So we have already established this is focal, right?
Yeah.
So for focal seizure, what would be your first choice usually? Anyone?
Yeah.
Or anyone wants to answer that?
Carbamazepine?
Yep, someone mentioned carbamazepine. So correct, carbama would be your first choice if you think this is focal, compared to sodium valproate or epilim, where we usually tend to start epilim when we think this is a generalized seizure. So for carbamazepine, what's the one thing that you need to worry about before you start the medication? Or what's the one thing you should consider? Or what's the side effect that you'll be worried about? SJS.
Stevens-Johnson syndrome.
Yeah, correct. So especially in Asians, carbamazepine causing Stevens-Johnson, carbamazepine causes more Stevens-Johnson in Asian compared to non-Asians. We always have to watch out for this side effect. You always have to tell the patient before you start carbamazepine that please inform us if there's a rash or if there's other side effects. So if there is an SJS or if you suspect there's an allergy reaction to carbamazepine, you need to stop it right away. Because if you don't and the patient keep taking, your SJS can progress into a more life-threatening complication. Okay?
Yeah. All right. Okay.
So
in terms of doctor, you can continue first.
there is another consideration for this patient in terms of valproate versus carbamazepine. Other than the focal and generalized, what would be the other consideration?
I think it would be her age, and she's also getting pregnant. Might be getting pregnant.
Yeah. So what we say, childbearing age, females lah.
Yeah.
So you would choose carbamazepine to valproate lah, obviously, because valproate is technically contraindicated or not supposed to be given to women of childbearing age, because the rate of teratogenicity is just high at the normal therapeutic dose. Of course, there can be argument that, there is always argument that very, very low doses of epilim doesn't cause much increase in teratogenicity. But on the other hand, there's also reports that says it can cause some autistic spectrum disorder. It can cause a bit lower cognition in the child. So if possible, try to avoid epilim in this age group and gender. So what would be the first choices or what would be the AEDs that are safe in this age group or gender? Carbama is one of them. Any
lamotrigine.
Other? Yep, lamotrigine, correct.
We also can give the levetiracetam, right?
Yeah, correct. And Keppra, which is the levetiracetam.
Yeah. Okay. Yeah, so doctor, like in terms of this, like when she had about 10 seizures in a year, in the past year. So this is considered a very quite a serious case, is it?
Depends on the cause of the recurrence. Like I said, if let's say she might tell she's compliant, but she might not be taking medication. Who knows? And number two is you might not be using the correct medication to start with. You might be giving, the Epilim, if you haven't tried Carbama, you probably can't really say that, oh, she's very resistant. Plus, she's only on 2 anti-epileptics so far. Yeah, of course, if you have 3 or more, it's already considered resistant, but then you should give the appropriate dose and the appropriate anti-epileptic before you consider it resistant.
All right. Okay. Yeah, thank you, doctor. I think the management of the patient goes a long way also, and we can take a whole lecture to talk about management. Yeah, but then we'll just move on to the PE first. I think we are done with the history. So in terms of PE, I think the PE that we actually do here would be a neurological PE. For the upper limb and lower limb, as well as the cranial nerve. But then in this patient, I think, according to this, everything is normal.
Unremarkable.
Unremarkable. Yeah. So in terms of this, like let's say in a seizure patient, like most of the time they have, when they present to the hospital, they might be out of the seizure already. So like, what are some of the things that we can actually examine, or like what are some of the signs that we can still elicit in terms of like these patients?
Most of the time, by the time we see the patient and the patient is out of the seizure episode, the examination will usually be normal. You might be able to find some complications like tongue biting or some injuries that will tell you, this is very likely a event where the patient really lost consciousness. In opposed to a patient who say, oh, she fell down, hit her head, but you don't really see much injuries and everything. But other signs are usually normal, I have to say, unless the patient memang has an underlying focal neurological deficit or a scar in the brain that might have given you some signs Let's say an old stroke or old encephalomalacia, old trauma or something. There are also, another thing is probably, I think someone mentioned just now in the differential earlier, someone mentioned thought paralysis, right?
Yeah.
So, you can find thought paralysis as in when the seizure has ended clinically, your patient might be weak on one side or weak on one limb or something. So if you find thought paralysis, then you will be thinking this is most likely a focal seizure.
All right. Yeah. Okay. So I think there's another question. Hi, doctor. I'd just like to ask regarding focal seizures. What would you ask in history to localize the specific point at which the seizure arises? And is such localization important?
Localization is important for us We have to manage the patient. We have to. How do I put this? Localization is important because we need to synchronize every single information that we have, as in history, physical examination, EEG, MRI, should all be in the same localization, especially for cases of resistant epilepsy where we are considering surgery and resection. So everything is the same place, it's concordant, then your likelihood of success for your epileptic surgery is higher. So that's why the history of the localization is important in terms of the future management of the patient. So how do you localize from history? Depends on the aura or depends on the first symptom of the seizure or the first sign or first symptom of the seizure. So like we mentioned just now, if it's occipital lobe, then you might see flashing lights. If it's a occipital temporal junction, your hallucination, you get hallucination, positive symptoms, but it might be a bit more complex than just flashing lights. So you might see figures, you might see shapes and colors. If you have a temporal lobe epilepsy, your aura might be epigastric discomfort, butterflies, you might get deja vu, you might get Jamai's vu, you might have some oral automatism, some hand automatism. If you have a parietal lobe seizure, which is very rare, you can have sensation, paresthesia, like a spreading sensation up your arms or up your legs. If your seizure starts right in the motor cortex or in the frontal, then you might not have much aura. It might just start straight away with a tonic chronic seizure.
Yep. All right. Okay, hope that answers the question. Yeah, we'll move on to, I think Doctor, so in terms of physical examination, is there anything you would like to add? Or, yeah, just now, that's about it.
Nothing much. I think that's about it.
Yeah, all right. Okay. So in terms of investigations, so yeah, so these are some of the investigations that were done. So wait, it's not coming out.
Yep.
I think that it's not coming out, but I think some of the investigations that yeah we thought we could do is like full blood count to rule out like any anemia or infections in terms of leukocytosis, and then do a renal profile to check for the electrolytes, whether the patient has hyponatremia, hypocalcemia, and hypomagnesemia.
Yep.
And yeah, I think do a blood glucose to check for hypoglycemia. So like yeah, is that I mean for blood tests, is there anything else?
Yeah, those are the routine tests that you should do for a first onset seizure where you're looking for a metabolic cause, as in you're looking for another cause of the seizure. So always look out for the electrolytes. The sugar is very important when you arrive in ED. If the patient is still seizuring or fitting, you must always check the reflow because you never know whether it's a severe hypoglycemia. Uncommonly, you can get a cardiac arrhythmia causing a syncope / or even a seizure, where you need to look out for this arrhythmia, especially in younger patients.
All right. So we will need to do a ECG as well.
ECG as well. Yes, correct.
Doctor, so in terms of EEG, if let's say we already know the patient is an epileptic patient and then they come in with recurrent seizure, do we still need to do an EEG?
If you have a previous EEG before and it's consistent with your information that you have, I probably might not repeat the EEG.
So in terms of like other brain scans, we wouldn't do also like in terms of CT, MRI, and we don't have to do any.
For this patient, I probably wouldn't because MRI, CT, PET already done, right?
Yeah.
For a new patient, first presentation, I might do it to be honest. If let's say I'm very certain this is a generalized seizure, as in an idiopathic generalized epilepsy, you might be able to escape by not doing, as in if it's very classical, if the clinical features are classical, the EEG are classical, it's slightly idiopathic, you can argue that you don't need to do a CT scan. But imaging, a CT or MR is definitely very important for focal seizures. Because when you have a focal seizure, it means there's a focality and you need to find out what is the focality.
Okay. Yeah. So in terms of investigations, any other investigations that we would need in terms of this case?
This case, I might consider doing a TDM for the epilim.
Okay.
Other than that, probably that would be it.
All right. Yeah. So I think the next would be management. I think we briefly talked about some of the management, and also I think we'll go to the second case first. We'll just come back to the management for like epilepsy as a whole at the end. Yeah. So I'll pass to Amanda to talk about the second case. Yeah.
Okay, thank you, Kenneth. Hello, Dr. Paul. I'm Amanda. I'm a second-year medical student.
Hi.
So I will bring us through the case 2. So this case 2 is prompt on the it is prompt in December 2019. So Miss Y, a 22-year-old. Sorry, Kenneth. The trigger is not. Yeah. So it is Miss Y, a 22-year-old Chinese lady with known childhood global developmental delay, presents with seizure for 10 minutes associated with 1 week fever. So in this case, doctor, what would you think? What is at first in your mind if it is something like this?
whether this would be a child with an underlying epilepsy, to be honest. Because there is this known childhood global developmental delay. So in all likelihood, the brain would have some changes or maybe either some structure or some physiological abnormalities. That's one thing. So the cause of the seizure might be because of an underlying epileptic condition. The 10-minute seizure duration would be an important distinction, where if the seizure is ongoing for 10 minutes, you probably should be worried, because this would be going to a realm of status already. But also depending on what is the type of the seizure, which is not mentioned here. Is it like tonic-clonic? Is it focal? Is it generalized? Is it an absence? So I still do not know that. The 1-week fever can be a trigger, can also be a cause. So that depends. You have to take more history to find out whether that's a trigger of a seizure or it could be something new that's happening that's causing a first onset seizure.
Okay,
Doctor,
so,
can I just ask? Can I just
sorry,
ask a
Doctor,
quick
can you
question?
say?
Sorry, Amanda. Can I just ask a question?
Sure.
Yeah, actually, I just like to ask, like, in
Yes.
terms of like global developmental delay, like normally is it because the patient, can it be like when the patient had a seizure and then that caused the global developmental delay, and then could it happen that way as well?
Yes, it could. Okay, I'll be honest. This is not something I'm very good at, lah. I mean, this goes in the realm of Pitt's neurology, but yeah, there are some epileptic condition or some epilepsy that causes either outward global developmental delay to start with, or it can cause some regression in the middle, where we call. I mean, this group of diseases or group of patients, we really classify them into epileptic encephalopathy, where the seizure or the prolonged epilepsy itself causes progressive cognitive damage or global developmental delay, and you get what I'm saying, right?
Yeah, thank you, Doctor.
It can go both ways, lah. It can be either a condition which causes both global developmental delay and seizure, or it can be a normal child with an insult or a onset at a later age, leading to epilepsy, and the uncontrolled epilepsy causing a developmental problem.
Yeah. Okay. All right. Thank you, Doctor. Yeah, we can pass back to Amanda to continue.
Okay. Okay, thank you, Doctor. So let's go through hopefully so it is taken from the Chinese is taken from the mother who is the main caretaker. Patient was actually reading when the seizure started, and we could not ask more regarding any aura pre-ictally. So during ictal, she experienced blank stare, did not respond to what the mother was saying, lasted for 10 minutes. Post-ictal drowsiness was present and became responsive after around 3 minutes. There's no jerking or stiffening of limbs, no drooling or uprolling of eyeballs, no urinary or bowel incontinence, no lip smacking, and no injuries. This is the third episode. Previous 2 episodes in 2013 and 2015 aborted spontaneously without any medication. So, sorry, should we go to the next slide? Okay, and she had constant fever for the past 1 week. It was relieved temporarily with paracetamol and antibiotics from GP. Last measured temperature was 36 degrees, developed runny nose for 2 days. No chills or rigors, no cough, no loss of appetite or loss of weight. So at this point of time, Doctor, what should we think of, and what should we be aware of in this case after hearing of it?
Can you go back to the previous slide? So the ictal condition is just a blank stare, right?
Yeah.
So what would you think this could be, or what do you think this type of seizure is?
I'm thinking it would be absence.
Could could very well be. So the fact that there's no jerking, no stiffening, nothing, just a non-responsive blank stare, you would be thinking this could be an absence. Have an absence that lasts 10 minutes, of course, is less dangerous than GTC, which lasts 10 minutes or even 5 minutes. For absence itself, I mean the different classification of status durations. Status duration has been evolving, I would say, from 30 minutes last time. Now we tend to take a 5 minutes duration for status, but that is for GTC. For a focal to call a status to call a focal seizure status, you should have more than 10 minutes. And an absence, to call it a status, if I'm not mistaken, is 30 minutes. So usually, I mean, the history part you've already gotten. You need to make it very sure that there's no jerking, no drooling, no incontinence. You can ask for other things like automatism and all that, or what the patient was doing, or was she continually doing whatever she was doing when she was having this blank stare. I mean, some patients might be holding a spoon and continue holding the spoon in the absence. You can also ask what was for absence, there are certain triggers. For this patient, it was reading, which was probably unusual as a trigger. So can you go to the next slide? The next thing will be also just now, the fever for the past 1 week. So we are still uncertain whether this is a trigger or this is a cause. But the fact that she has epilepsy, I mean, she had a few events in the past that's similar. Most likely she might have an underlying epilepsy. So can you guys still hear me? I'm getting a message that says my Wi-Fi is a bit poor, actually.
Yes, I can still hear you, doctor.
Okay, so the fact that she has and I would make sure whether you think this is likely something like a meningitis and encephalitis.
Sorry, doctor. The last few seconds we can't hear you clearly.
Yeah. So I've said, so for fever, we still need to find out whether this is a trigger or a cause. Yeah, is it better now, or are you still having problems with my voice?
Yes, it's better now. Sorry, doctor, there's one question in the chat. Right. Tian Yin. Hi, doctor. Just like to ask regarding focal seizures, what would you ask in history to localize the seizure?
I think we answered that question already just now. I think that was from the previous case.
Yeah, that was answered already.
Sorry.
Yeah.
Actually, doctor, for like fever, anything else that could be the precipitating factors that we should think about, especially in girls, or just like what in the last case have mentioned, menstruation and stuff we should be asking about?
You need to localize where is the fever coming from, I think. If you have a very clear source of fever, you probably might just blame the fever on that location. Unless say the patient has been having cough for the past 1 week with sputum, pleuritic chest pain, hemoptysis, then most likely you think the fever is coming from the lung. If your patient is having some abdominal pain, abdominal tenderness, diarrhea, you might think it's something intra-abdominal. If the patient is having a lot of headache, neck pain, neck stiffness, if you find some focal neurological deficit, confusion, then you would likely think this could be a intracranial infection that might have been the cause of the seizure.
Okay, understood. So we'll be going through the past medical history for this case. So actually this patient had a history of childhood fit and had a global developmental delay, which it is since 1 year old was only able to walk at the age of 1.5. 1.5 years old, sorry. So by this time we would be thinking about, because patient is having absence, we will be thinking about could it be JAE, CAE. About this, because I have read about CAE would have patient could outgrow of CAE, something like that. Would patients still have seizure episodes if they have been out of that range of age, doctor?
Usually CAE is quite benign. The prognosis is not bad. It's quite good actually. Like you said, they can outgrow the seizure. So by the time they grow up, their absence will usually get less and less. And I mean, they sometimes can have GTC, but usually it's not so common, and they might remit spontaneously. It shouldn't cause so much of this global developmental delay, I would think. If you have global developmental delay together with epilepsy, you probably should think about something else, something either genetic or structural in the brain that is rather than an idiopathic epileptic condition.
Oh, okay, understood. Okay, so anything else that we should be asking about for the past medical history in this case? Like, what should we be focusing on, or this would be kind of enough?
You probably can ask a bit more about the past medical history or what. I mean, yeah, she has global developmental delay, but the information given was only the motor part. You can ask more a bit on the social part in terms of the delay. Social part, language part, whether there was any behavioral problems as she was growing up, whether she can, what can she do, what can she follow, especially at this moment when she's already 22 years old, what's her functional status, what can she do, is she functioning normally, is she going to work and everything.
Okay, so only if, so like what mentioned just now, we will be like thinking if there is behavioral changes, we will be thinking more on and the type of seizure. Is it like what you mentioned in the last case?
No, yeah, you need to know the baseline, then only you can know whether anything has changed.
Okay.
If you do not know the baseline, what is the functional level or what's the cognition level of baseline, you won't be able to judge whether the current state that the patient is at now, is it normal or is it abnormal?
Okay, understood. So for the further history of this patient, the drug history, the mother does not know the name of the medicine that is being taken. She's allergic to ceftriaxone. She develops rashes because of it. The family history would be there's no history of epilepsy or seizure, no history of malignancy. Social history, she does not smoke or drink, and she's currently living with her family in Subang Jaya. So so we would be moving on to PE. Should we be doing what like the last case would be, like the vitals, general inspection, and neurological examination as well?
You mean as the physical examination?
Yeah.
Yeah, you probably would do a standard neurological examination for this patient as well. But you also will be looking for things like neck stiffness, Koenig sign, Brzezinski, if you're looking for meningitis, or whatever the source of the infection is. Look for listen to the lungs, feel the abdomen, make sure it's not tender.
Okay, so, okay.
Yeah, excuse me. I'd just like to ask, doctor. So just now you mentioned like the patient might have some disorders that have caused the global developmental delay. So like, is there any particular disease that could cause this delay and then cause a seizure? Is there any is it like a syndrome or something like that that causes that?
It could be a perinatal or a neonatal insult, like a hypoxic event or a severe infection. It could be an underlying genetic condition, which, like I say, probably not a very good subject for me to go into detail, because, like I said, this is under PEDS neurology. My genetics is probably not that good.
Okay. Right, doctor. So also another question, like in terms of juvenile absence seizure, let's say another case, like because patient is 22 years old, would it still be considered a juvenile?
But her onset was a bit younger, I think.
Yeah. The onset
Yeah, you probably call it. I mean, the typical juvenile onset is more during the teenage age lah. So depends on which age you have the onset of seizure at. You can still call it juvenile absence, I guess.
All right. Okay.
Okay, so we'll be moving on to the investigations. That, doctor, what should we be first doing for this for the investigation for this case? What should be first line? What should we do first?
I mean, the standard stuff, you can do the routine bloods and to make sure there's no other problems. You can do an ESR, CRP, blood culture, even to look for a source of infection, X-rays. You can consider doing a lumbar puncture if you think this is possible meningitis. But like I said, considering the past history of epilepsy, this might be a trigger rather than a cause. Brain imaging and an EEG will be important in this case.
Okay, understood. So, do we still need to do? Sorry, nothing. There's one question in the chat saying that by Elena, doctor, how do we know or how do we ask about the baseline for social and behavioral for this patient?
You have to ask the family. The family that's staying together with the patient. What can she do normally? What is she doing right now? I mean, for a 22-year-old, is she going to school? Is she going to a normal school, special school? Is her reading normal? Is her speech normal? Is her behavior normal or abnormal? Does she still throw tantrums and all that? Or is she normal socially? When she's talking, can you understand her? Can she understand you? So all those are how you take the history on the baseline. Can she function in the society? Can she go out? Does she have friends? So you have to take a very clear baseline social history.
Okay, understood. So, okay. So, actually, doctor, so of all this, this is more likely to be an epilepsy due to a brain abnormality, is it?
You put in a general way, yes, I guess so. I mean, all epilepsies are due to brain abnormalities.
Oh, okay. Okay, sorry, doctor. So, like what we had for the last case as well, what are the general management options for epilepsy patients? Like, when do we start? Which AED that we should use?
Okay, for this patient, what would be the AED you would use? I mean, we suspect that this is an absence, right?
Yes.
So what AED would be the first line?
Lamotrigine.
Yeah. Well, for absence in particular, the more effective one will be Epilim. So that's why the social history is again important. So you also have to find out whether she is, I mean, if she's socially normal, does she have a boyfriend? Is she intending to get married? You can use lamotrigine. It's not very effective for absence. So I probably would not choose that as a first line. Etosuximide, yes, in the books you always hear about etosuximide, but I don't think we have it here. You can consider Capra also, I guess, if you want a safer option for childbearing age.
Okay.
Doctor, is there any reason why we don't have etosuximide? Because I think we kind of hear a lot about etosuximide for absence.
Correct. I'm not too sure why, and I'm also not too sure whether we already have etosuximide, but as far as I know, we don't have it.
Alright, okay.
So when to start AED as a principle? So in general, we always teach that if you have one seizure, okay, it depends on a lot of things actually. The most general principle is one seizure you can wait. If you have two seizures, then you should start an epileptic. But there are a lot of conditions where one seizure you can also start an AED. Can some of you maybe name a few examples? What kind of situation where you will start AED even if the patient is having a first onset seizure or first seizure event.
Yeah, I think we can just comment in the chat box some of the answer.
Post-stroke seizure, yes. If it's a remote symptomatic seizure, yes, I will probably start. TBI, yes, correct. If they have future predisposition for seizure, that's quite general, right? Yeah, correct. So,
That's epileptic.
Yep, correct. So what all of you have mentioned just in general lah. It's when you have a predisposition to get more seizure. We usually take a very rough cutoff of 60% plus or 2/3 risk of getting a recurrent seizure. Meaning that if you have an underlying brain abnormality, let's say a scar or a TBI or a stroke, if you have EEG abnormalities, or if you have 2 seizure events, all this will give you a higher than 66% risk of getting a second seizure. So you will start AED for all these conditions. That's one situation. Is there any other situation that you might start AED for first seizure?
Would it be
Is it
SOL?
like
SOL would be part of your brain abnormality. It's still in the same category. Nocturnal seizure. On the other hand, nocturnal seizure, I might consider as in the other way lah. You might not need to start anti-epileptic, because if the seizure is very brief, all happen during sleep, and the patient is not keen for anti-epileptic, you might not start, or you might be a bit less aggressive in controlling the seizure, because your risk of injury is probably very low. If you have no past medical, if you have no history of like status epilepticus and your seizure is quite stable, you can negotiate in terms of the seizure control, I guess. So the other condition would be if your patient insists or requests for medication. Let's say they are in a social situation or an occupational situation where they cannot afford to have a seizure. They might want the anti-epileptic even with the first seizure.
Okay, Dr. And like when exactly should we like change AED? Only when patient cannot stand the side effects, or only when it doesn't help?
So for both conditions, you can change the AED lah. If you have side effects, definitely change, because if the patient can't take the medication, no point continuing. If your medication is not working, you can change. I mean, you can either add on or change lah. That depends on the response of the patient. If let's say you use the first AED and the seizure is controlled halfway, then you might consider to add on rather than change. If you start the first AED and the seizure, I mean, you did nothing to the seizure, there's no reduction at all, then you think it's not working, then you might just consider switching instead of adding on. Or if there are, let's say, other things, let's say, because anti-epileptic is, they have a lot of drug interaction in anti-epileptic. So if let's say the patient is diagnosed with TB, you don't want a enzyme inducer kind of medication, then you might consider changing. Or if the patient let's say it's a childbearing age patient, let's say from pediatric, she will start on Epilim, then as she move to adult, you might want to consider changing it to more pregnancy safe medication, then you might consider changing as well.
Okay. And because I think I also read this in Coma and Clark as well, this epilepsy surgery. So when exactly do we do this, or this is at the very, very last resort only we do?
No, this is not the very last resort. This is a treatment option for resistant epilepsy. So when you have epilepsy which you can't control with medication, a resistant one, despite correct dose, despite correct medication and the patient compliance, then you would consider evaluating the patient for epileptic surgery. But there are a lot of conditions you have to fulfill before you do the surgery. Namely, you have to localize the lesion. You have to be very certain there's a part of the brain that you can chop off correctly and chop off safely. Meaning that if there's a malformation, you're very certain the malformation is the cause of the seizure. And if the area where the lesion is a non-eloquent area, meaning that if you chop off that part, there won't be a new neurological deficit. She won't, let's say, have a very bad memory problem, language impairment, motor function loss. So there are a lot of pros and cons that you need to weigh. But
Okay,
in general, it's for resistant epilepsy.
Okay. So doctor, like when do we, because sometimes patient may just say that they don't want to eat, they don't want to take AED anymore. And so when exactly can we withdraw AED?
In general, you can consider withdrawing AED when the patient is seizure free for about 2 to 5 years. So that's in general. You should always tell them if you withdraw the anti-epileptic, there's probably a 30% chance the seizure might come back in the next 2 to 10 years. However, there's other conditions that you might not withdraw anti-epileptic, or you might advise the patient to continue taking. Certain syndromes like, let's say JME, they tend to get seizure predisposition for a very, very long time, even up to late adulthood. So taking off the AED might not be a very good idea. For, let's say, remote symptomatic seizure, your lifelong seizure risk is also not low. So you might consider giving them lifelong anti-epileptic as well. Or if, let's say, your epilepsy is very hard to control in the past, you have a very, very florid EEG changes, then you might also consider not withholding the anti-epileptic.
Okay, thank you, doctor. So we'll be moving on to the next slide.
Yeah, I think this one is I think is from the consensus on the seizure epilepsy management. Yeah, I think these are some of the drugs that we can use for the different seizures, right?
Yep.
Yeah. Okay. I think we also have gone through that so I think we can.
Yeah.
Yeah. So this is actually just a slide on the mechanism of action. So we can see that there's really a lot of different types of drugs for AED. Yep.
Yeah.
So I think we have come to an end for the for this session for the cases as well. Yeah. So like before we end, is there anything that Dr. Toy you would like to tell us in addition to what we have discussed about epilepsy?
Yeah. In summary, when you take history, always think whether this is an epilepsy or not. Whether this could be other things like hypoglycemia, cardiogenic arrhythmias, or even vasovagal syncope, pseudo seizures. And when you decide this is likely an seizure event, then you have to think of what's the cause of the seizure. Is it like electrolyte imbalance, hypoglycemia, symptomatic, secondary to a genetic condition or structural brain problem? And next, you also have to ask about triggers. Then the pre-ictal, ictal, post-ictal, you need to get it correct in your history. And you probably need to go a bit more into social if you come across patient epilepsy, because usually they tend to have either some or a lot of social problems that you should tackle as well.
Okay. Yeah. All right. Thanks, Doctor. We have a question, Doctor. For epileptic patient, the semiology should be the same every time, right? Is it common for patient to experience different semiology?
Theoretically, yes, the semiology should be the same every time. However, some epilepsy might evolve in a certain way, as in, because Like let's say a very long-standing epilepsy, let's say a mesial temporal sclerosis. If you do serial imaging, you will see the temporal lobe getting smaller and smaller, atrophy, or there are some changes that are structurally related. So in a way, it can evolve in some way. Maybe some aura that were frequent before this might be less, or maybe before this the frequent presentation is focal, then now it's generalized. But it doesn't mean that the cause of the seizure the cause of the seizure might still be the same lesion, might still be the same epilepsy. But if you have a very clear different semiology, as in you should also consider whether the seizure that you're dealing with currently is a different etiology lah. Let's say certain metabolic triggers or certain alcohol withdrawal or intracranial infection.
All right. Okay. Doctor, so there's also another question. For the first case, since the patient is diagnosed with focal to bilateral seizure, so will we choose to give patient a focal seizure medication, or you give generalized seizure medication?
You will still give focal because the seizure started focally, right? So you're technically controlling a focal. The secondary generalization is just a spread. If you control the focal, then your secondary generalization won't occur.
Okay. All right. So, doctor, which guideline will you follow for patient with epilepsy allowed to obtain the driving license, or patient with epilepsy allowed to drive after they recover?
Yeah, that's one thing I forgot to mention also. Yeah, you should always talk to your patients about driving, about dangerous activities and all that, and avoiding all those activities after the seizure lah. Education lah, basically. Which guideline do I follow? I don't think Malaysia has a very strong guideline for driving with epilepsy. I used to look at the UK guidelines lah when I was doing MRCP, so I think that's quite a good and a simple guideline to follow.
Okay. All right. So, doctor, is there a specific reason or mechanism to why Carba is chosen as first line in focal while we use valproate for general, or is it just because it has been shown to be more effective after like research?
I do not know. Not sure. Probably there are some mechanism that makes Carba more effective for focal, but I'm not sure what's the answer to that.
Okay. All right. So there's another question. Doctor, is EEG indicated in all patients with no known medical illness who presents with seizure for the first time?
Yeah, I will probably do EEG for all patients who present with seizure for the first time. It's you can either look for epileptic syndromes, you can look for focal cortical abnormalities, or if let's say so even if it's a provoked seizure or symptomatic seizure, I'll probably also do an EEG.
Okay, yeah. I think there's no more additional questions. Yep. All right. I think that's all for the session today. Yeah. So thank you, Dr. Tor, for coming on as well. Yeah.
Sure. Thank you.
All right. So yeah. Thank you, Doctor.
Okay. All the
Good
best.
night. Yeah.
Yep. Good night.
So before we end, we just like the participants to help fill in a feedback form. So I've actually sent the link. I'll send another time. So you can fill. Yeah. All right. Okay. Thank you again, Doctor.
Okay. See you.
Yeah.
Thank you, doctor.
Okay.
Thank you, doctor.
Welcome.
Thank you, doctor.